As you work your way up, this is S1, 5, 4, 3, 2. So here the conus appears to be above the level of L2, and that is considered normal. The level of the conus should never be below L3. Here again, this is a flat sacral element, S5, 4, 3, 2, and then you move your transducer up to start counting the lumbar elements. Panorama is a very nice way of documenting how you're counting the elements. Again, here we have this transition between L5, S1, and as we count high, we see that this chord ends at L2, which is normal. Here's another case. Is this in a normal level or abnormal level? By counting, one can estimate that the tip is at L2, which is normal. Below L3 is abnormal. The L2-L3 disc space is borderline, and here you must be quite careful in making sure that your counting is correct. This is when counting from the ribs down may be useful, and if still in the indeterminate range, putting a marker on and getting a radiograph may help confirm the position. The transverse planes are helpful in identifying where the last rib is. It allows us to look at the pulsation of the nerve roots, which should be normal if the cord is not tethered. Here we're near the tip of the conus, and these are all nerve roots, which on real time will move with respiration. The filum terminale should be measured at about L5, S1 and should not measure greater than 2 millimeters. When thicker than 2 millimeters, it should be considered possibly having a fatty filum with some lipoma associated with it. There are several normal variants that we will discuss. The ventriculus terminalis, as I had mentioned, is incomplete regression of the terminal ventricle, and as long as it measures less than 5 millimeters, it may be considered a normal variant in children less than 5 years of age. If it's larger and way above the conus, you may worry that this is indeed a true syrinx. Over time, the ventriculus terminalis should remain stable and not enlarge, and this can also help differentiate it from a true syrinx. A filar cyst is a cyst just distal to the conus. This is also considered a normal variant and can be found with many other spine anomalies, and can be seen in up to 3% of children with tethered cords. This is, however, considered a normal variant and is not a true cyst. It's felt to possibly be a collection of CSF between nerve roots that mimic a cyst. And here's an example of another filar cyst. These are difficult to see by MRI due to the high signal of the cyst and the very thin nerve roots surrounding it. As mentioned, the filum terminale should not measure more than 2 millimeters. If it's thick, it may be secondary to lipoma of the filum. We also look carefully for possible lipomas of the canal, and sometimes clumping of the nerve roots can mimic a lipoma. With repositioning of the infant, if there's movement, this should be documented as a true nerve root clumping and not a true mass. Pseudo-sinus tracts can mimic tracts from the dimple into the canal, but remember that these are so low at the conus, at the coccyx, that these are simply cartilaginous areas that do not have direct communication to the spinal canal. These are several unusual coccyx that seem to course to the skin, can mimic a sinus tract, but are simply cartilaginous. Let's talk about the pathology of the lumbar spine. As mentioned, if the filum measures more than 2 millimeters, there may be fat within the filum. This may be associated with tethering, but the patient may be asymptomatic and could be considered a normal variant if isolated. If the mass becomes very thick, you can call it a lipoma. And again, the measurement should be at the level of the L5-S1 vertebra. It is often associated with cord tethering and myelomeningoceles. Lipomas are secondary to premature separation of the neural ectoderm from the cutaneous tissues. The mesenchyme can be trapped between the neural folds. They can be intradural, be associated with lipomyelomeningoceles, or be associated with the lipofibroma of the terminal filum. Interestingly, the fat can get bigger and smaller, and prognosis is varied due to the association of other anomalies. It can be difficult to completely resect these, so they can come back and retether. By ultrasound, we see hyperechoic mass with intra or extradural extension. Very commonly, it's in the dorsal aspect of the cord, most commonly seen in the lumbosacral area. Often we talk about tethered cord as the primary diagnosis when we're doing an ultrasound in a neonate. By definition, as mentioned, tethered cord is when the conus is below the L2, L3 disc space. It's incomplete regression or failed involution of the terminal cord. This traction causes the conus and the nerve roots to be dorsally positioned. The nerves are tight and can get injured by the stretching of the cord. These are often associated with a thickened filum terminale or fibrolipoma. Here we have an example of a tethered cord, low down, with the conus way below the L5 vertebra. Tethered cords, as mentioned, are associated with fatty filums. Here we see a very thickened fatty filum at the S1 level. Tethered cord is associated with scoliosis, anal atresia, sinus tracts, cysts. Unfortunately, the clinical presentation may be late with difficulty ambulating and bladder and bowel dysfunction. This is secondary to the abnormal reflexes from stretching of the nerve roots. Treatment is surgical release, and it's important to recognize this early for improvement in function. Prognosis varies dependent on the severity of the tethering and how long the damage has been occurring for before it's been identified. Some children may retether and require re-release surgery. Lipomyelomeningocele are defective disjunction with entrapment of mesenchyme in contact with the neural tube. These are skin covered and may have dysmorphic spinal lesions. Here we have a case of a lipomyelomeningocele with a large sac. It's skin covered but has a large mass with surrounding CSF fluid. On MR imaging, one can document the tethering of the cord and the complex fat that is both under the skin and in the intradural component. Here we have another case of a cord that's tethered with a fatty lipomyelomeningocele distally. Caudal regression is secondary to abnormal mesodermal formation of caudal cell mass. This is most commonly associated with mothers with diabetes, but has been described in children with anal anomalies, GU anomalies, and the VATE-RL sequence. Notice how the blunting of the cord is, and this is low and tethered at L4. When correlated with the MR, one sees again this blunted cord, low at L4. Typically, they're associated with some sacral agenesis as well. Neonatologists may ask you to do an ultrasound of the spine to look for epidural or subdural hematomas. These are fairly rare, but can occur after a failed lumbar puncture. Ultrasound can help to decide if a reattempt at a lumbar puncture can occur and can be used to guide where the needle is placed. Here we have a normal transverse spine. We have CSF surrounding the cord and the nerve roots. With an epidural or subdural hematoma, the CSF is obliterated by the blood. Here on a panorama, we see no CSF fluid. This is all filled with blood that is echogenic, kind of compressing and pulling the nerve roots together that are now clumped. Here's another case of a hematoma surrounding and clumping the nerve roots, and this is a normal comparison with some CSF noted. This case from Judy Estroff from Boston Children's demonstrates an echogenic mass that mimics a hematoma. However, it's quite expansile and there was no history of a lumbar tap. This is a term infant who had decreased lower extremity tone, and by ultrasound we see a mass essentially obliterating the spinal canal. This turned out to be a neuroblastoma with intraspinal extension in the newborn period. Here's a newborn with a skin-covered mass, but it's way low below the coccyx. It's cystic, and there was no evidence of cord tethering. This was a sacrococcygeal teratoma. Notice the normal position of the cord and the skin-covered cystic mass at the coccyx. Ultrasound was particularly helpful in following this case even at surgery during the excision. So ultrasound allows for accurate detection and characterization of spinal abnormalities in the first few weeks of life. Familiarization with the ultrasound appearance of the normal anatomy, pitfalls that simulate disease, and understanding the common pathology is essential for successful imaging of the neonatal spine.